Um, Thanks very much for giving us your time today. We were going to present two projects today, but unfortunately Sarah is unwell today, so we she won't be able to present her project, but we do wish her a speedy recovery. But we've still got Gareth and his very exciting and innovative project that he's going to tell us all about in due course. So to introduce myself, I'm Dan Clark. I'm a GP in Doncaster, but I'm also clinical lead for heart failure at South Yorkshire ICB. Want to start by giving a bit of context to heart failure and the problem it presents. So heart failure is a condition where the heart doesn't pump as well as it should do.
Bit much, isn't it?
And it causes symptoms such as shortness of breath, fatigue,
to work full time,
lower limbs.
And go to 3 days.
Oh, we just need to mute somebody, I think. I'm getting, yeah, great, thank you. Yeah, it causes shortness of breath, fatigue, and lower limb swimming, which can lead to significant mortality and morbidity, because it's a chronic disabling condition. We've got over 200,000 new diagnoses of heart failure each year. And very interestingly, in 2018, it was reported to be, the burden was reported to be similar to the 4 most common cancers combined. And that really, to me, seems very significant and something that I think heart failure doesn't get the recognition for.
And the interjecting, Dan, the prognosis is probably as bad, if not worse, than most of the common causes of cancer.
Absolutely. Thanks, Gareth. Yeah. It accounts for 2% of the budget, and actually 70% of that is for hospital admissions. It's the most common cause of hospitalisation in the over 65s. Patients often have very extended stays in hospital and have a 30% risk of readmission. There are more than 100,000 admissions each year for heart failure in the UK. And probably the headline that I want you to take away more than anything else is that South Yorkshire has the highest admission rate for heart failure in England. So there's a missed opportunity here. This infographic from the British Heart Foundation sort of describes it really well. Around 80% of heart failure diagnoses are made in hospital, but actually 40% of these people have symptoms before they go into hospital that should trigger an early assessment. So the British Heart Foundation is highlighting that if we get these people earlier,
I can see it, but I just can't hear it.
That by diagnosing people with heart failure earlier, we're getting them the specialist care they need. It is possible to cut emergency admissions, and just remind you that if we go back to that previous slide, 70% of the cost of heart failure is on hospital admissions. So if we can reduce that, we can reduce the associated cost with heart failure. So now I've described the problem, I want to talk about Gareth's project and a potential solution that sort of goes a long way to help with this. Gareth is heading up a project with money from the Cardiac Network from NHS England, and his project has shown that how to get a faster time to diagnosis, which is then for reducing the patient exposure to deterioration and a possible admission. And then this is and he's also demonstrated financial savings through saved appointments in cardiology outpatients, and he's demonstrating an improved collaboration between primary and secondary care. And we truly believe this should become sort of standard practice within the region and even beyond. But let me hand over to Gareth now, who can talk you through his presentation. So do you want to tell me, Gareth, when you want to change slides? If I go across like that for you, is that okay? Can you see them okay?
Yes, thank you, Dan. Yes. Right. Thank you for the introduction. So I'm Gareth Archer. I'm a consultant cardiologist in Doncaster and Bassetlaw. I've got subspecialty interests in heart failure and imaging. And I started in Doncaster in February 2022, so 3 years now. I think we've got a mix of audience. I don't think we've got any cardiologists. I'd like this to be a bit interactive. So if people think along the way whether they could have done things better, differently, what issues they might find either in secondary care or primary care with any of the things that we've tried or doing at the moment, then please just shout out and we can have a discussion. It'd be nice to get some feedback as to how you think this may work in the area of practice that you have or involved in. So I mean, I just wanted to go back to just how important, if you look at the evidence and the current guidelines about how quickly we should see people with heart failure, we know it's a terrible disease, as Dan's mentioned. Your NT-proBNP basically determines, it's helpful for determining risk and prognosis. For instance, if you've got NT-proBNP of greater than 10,000, you've got a significant mortality and morbidity, with 50% either dying or being admitted into hospital acutely within 6 months. Within 6 months, if they've not started heart failure therapy. So the guidelines are, if you're suspecting heart failure, you do a barrage of tests, including an NT-proBNP. And if it's greater than 2,000, you're at high risk and you should be assessed with an echo and seen by a specialist within 2 weeks. If your NT-proBNP is between 400 and 2,000, then you should be seen with an echo within 6 weeks. So low risk patients. And this was the challenge that we faced when I started. And it's the same in every secondary care in terms of long waiting lists for new patient appointments. So just to put it in context, when I started, we had what was happening for our heart failure patients is if you had an NT-proBNP, you were triaged to an urgent face-to-face new patient appointment. And our urgent waiting list was at that time between 1 and 2 months, and they extended to 2 to 3 months. And our routine follow-ups were almost 6 months to 8 months. So that's where you would see the 400 to 2,000. And the way we used to run this, it was run by the cardiac specialist nurses and the heart failure nurses in the diagnostic clinic. And they would see the patient, often without an echocardiogram, or if they could find an echo slot on the day, they'd get an echo slot. And if they get the echo diagnosis, great. Often they didn't have this, and therefore they'd refer for an echo, which was another wait. We're actually pretty good in our echo department. We've never had really long waits for our echo department, even throughout the pandemic. And you get an echo back. That echo will go back to the consultant that was supervising clinic, and they'd advise about the next management steps. So that's where we are. And you can imagine how many delays there may be in this patient receiving the right diagnosis and the treatment. And the first thing first, I mean, there's lots of delays in primary care, and I've got a few case examples. They're not special selected cases. I just went through our list of heart failure clinics, and you'll see later on, these are patients just selected with severe or significant LV impairments, and the journey they went through our heart failure services. So I think we can go. Is there any questions about what's expected? I mean, if anybody's involved in heart failure services, is anybody else managing to see these patients with an echocardiogram within 2 weeks or 6 weeks, respectively? Silence. Okay, we'll move on. Next slide, Dan, please. Oh, can I move it? I might be able to move it. There we go. I can navigate it forward. There we go. So we were looking at ways how we might be able to improve this service, and we thought because of the long waiting list for outpatients, some form of virtual approach to try and get the treatment sooner for the patients may be helpful. And there was some funding from NHS England through the cardiac networks, and we applied for that because we knew we had an issue with getting treatments, and they through the application process, they awarded us just a little over £40,000 to set up a virtual heart failure MDT. And this is just an excerpt of one of the patients that we discussed. So the pathway's changed in a number of ways, and I'll take you through the different steps we've done. So when we were able to set up the heart failure MDT, virtual pathway, we changed a number of things. And this just shows that this patient, they were known to have LV impairment. They've got ischemic heart disease. They're breathless. They're deteriorated in.
Sorry, Gareth. I'm just going to interrupt because I'm not sure we're all seeing the same slide. Jess, which side are you seeing?
Should say virtual heart failure MDT at the top.
No, we've got AIMS.
Oh,
I think I'm in control, Gareth. So you tell me which slide you want.
I couldn't see the slides that you were showing there.
Okay.
Right, are we synced now?
Which heart failure MDT? Yeah. Slide 8.
Heart failure MDT.
Yeah.
Right. If I move forwards, does that move forwards to AIMS now?
No.
No.
How about now?
But if I do it, it does.
Sorry, technological glitch. Can you see the heart failure MDT now?
No, I think it's me in control, Gareth. So
all right, if you go back to the heart failure MDT, then
you just tell me when you want to click. Yeah.
I'll have to click at the same time because your slides aren't moving at the same time as my slides for some reason.
Okay, yeah. We'll go with slide numbers then to help. All right. Apologies for interrupting.
No, that's fine. So it should be on 8 of 26, I think, there. Virtual heart failure MDT. So essentially, this was a GP. We got an echo through actually to show there was significant LV impairment. They had a known diagnosis already, so perhaps they didn't really need to come to the diagnostic heart failure clinic. But we were quite worried about them because their NT-proBNP was 4,000. They were on some treatment already for their heart failure, but we were able to advise what medications to start based on their recent blood tests and their current symptoms and signs of fluid overload. And this, the aim for this is essentially to keep things at bay till they can get seen in one of the urgent clinics. So that was the first thing to set up, our virtual heart failure MDT, and that comprises a consultant cardiologist, me, with an interest in heart failure. We have heart failure specialist nurses within the hospital. We have the community heart failure specialist nurses that attend just to try and join up between secondary and primary care. And we have a cardiac physiologist that can review the echoes and just make sure we're all happy with that. And then anybody else, it's an open forum, people can attend, so they can bring cases. And we had lots of different aims when we set up the MDT, which is the next slide, Dan. Which is slide 9.
Slide 9.
So as Dan says, if we can get this treatment to these patients quicker, more efficiently, and the right treatment, we can reduce the morbidity and mortality. We want to try and avoid unplanned admissions, both to A&E and then the long inpatient stays. And an average heart failure inpatient stay is about 2 weeks, so quite significant resources into that. We wanted to make sure we were seeing the right patients in the right clinic. So a lot of these patients that are referred with query heart failure don't have heart failure. They have other conditions, COPD, pulmonary emboli we see occasionally, atrial fibrillation, or renal disease that can also put your NT-proBNP up. So we're trying to select the patients who will benefit from seeing a cardiologist. Heart failure specialist nurses, in most regions, we don't have enough of them in the country, so in most regions they're quite stretched. If we can aid with the MDT to try and initiate some of the four main pillars of heart failure therapy that most people are familiar with now, then that reduces some of the burden on the heart failure specialist nurses, especially if they're established on 2 or 3 of the 4 pillars before they get reviewed. And then it's just a case of up titration rather than initiation. Education, obviously, come to this meeting, it's not really educational, just showing how we work, but the MDT is quite useful in terms of education. There's a lot of people know how to manage heart failure, or at least the theory behind it in terms of the medications that should be started and up titrated quickly. but there's not often the confidence to apply that clinically. So I often find educational meetings useful, but actually seeing how things done in practice is often gets the message home a little bit better. We didn't offer a cardio-oncology service in our hospital, and this gave the opportunity to the oncologists at Weston Park and locally to join and discuss patients that they're concerned about that are on cancer therapy or about to start cancer therapy, and how best to manage their LV dysfunction or their risks going forwards. I've put this in facilitate non-cardiac procedures. It wasn't really an aim of the project, but it seems to have helped somewhat. We often the anaesthetists either hear a murmur or are concerned about LV function or new changes, left bundle branch block on an ECG prior to surgery, and they often get an echo, and the echo comes back as either borderline low or impaired LV function, and they want to know, do they need to delay their surgery for a cardiology review? And as I said, if they refer to in the usual pathway, it would take at least 2 to 3 months. Patients' elective hips or knees were delayed, and often that wasn't really needed. So we've had a few anaesthetists that join us on the MDT, and when I can say, well, actually, it's borderline low function, a bit hypertensive, you've got reason to put them on ACE inhibitors, beta blockers, and you can go ahead with the surgery. It's relatively low risk from a heart perspective. And that's helped facilitate the management of our non-cardiac patients as well. We invite everybody, including primary care. As I said, we send out specific invites, but there is an open invite as well, just in terms of education. We're trying and link everybody up so the community heart failure nurses, the GPs, with the patient. Okay, next slide then. Any questions so far? So slide 10. So I'm going to try and show you how, I'm going to show you, try and demonstrate how we've either met these aims or how we are going along the way to try and meet these aims. So when we started this back, actually the first MDT was in December in 2023, and as I said, we send invites out. We advertise generally through emails and GP practices, but also within the hospital. And we've had initially a fairly variable response. So we have a mixture of people joining. I suppose that the thing that's disappointed me somewhat is the take up from primary care, I suppose, just to discuss the patient. I saw this as a bit of a face-to-face, well, virtual face-to-face advice and guidance. And because advice and guidance is a bit clunky, and often you don't have the information that you want or request, and you send multiple emails and still don't get the answer that you're wanting for the patient. So a 5-minute face-to-face chat just enables people to understand the concerns, what direction, what the need is for that patient, and often we can head off either the need to see them in clinic or give some advice. And the common ones that we invite to the MDTs are often 90-plus-year-old patients that are very frail from care homes that refer with leg swelling and an NT-proBNP. And often these patients, the risk or not a risk, or the inconvenience of bringing them into hospital for an echo and a cardiology appointment way outweighs the benefit, and what we need to do is concentrate on symptoms. So it's a bit of practical management and giving support for these decisions in certain cases. As you can see, quite variable. Some months are better. We're getting through quite a number of cases in each meeting, but again, the uptake's been quite variable. Next slide then, please, Dan.
Slide 11.
Slide 11. And you can see we seem to make a difference in terms of management plan. People bring the cases, we make it in a fast, or many of the cases that we discuss, management changes. The purest view in terms of evidence-based medicine would be to say, well, did those changes make a huge benefit to the patient? We're looking at at the moment, but we're hoping they will reduce the admissions and improve the care of patients. And certainly the feedback that we've had from the clinicians that have been involved have been very, very positive. Next slide, Dan, please. The 12.
Number 12.
And we're actually getting better than this, actually, in terms of slots that we save. So as I said, I probably wasn't very clear on this in terms of the processes that we did change at the same time as offering the MDT. So the offer of the MDT enabled us to change the process in terms of the order in which things were done. So when we get referred now a patient with heart failure, our echo team, our cardiorespiratory physiologist or cardiac physiologist, triage the referral. And if they've got an NT-proBNP, they will look back, see if they've had an echo in recent times, so 2 years, because often there's no need to repeat an echo, particularly if they've got a known diagnosis, and therefore they don't need to be seen in a diagnostic cardiology clinic. They'll also look to see whether they're known to a cardiologist. The thing that I hate personally is duplication of work for everybody, trying to reduce that. And sometimes we can answer the question just based on the referral, and I'll get back to the GP about that, or whoever's referred them into the heart failure clinic, or invite them to the MDT. So when they triage, everybody now, pretty much, or most people are getting, with an NT-proBNP of greater than 2,000, are getting an echo within 2 weeks, and an NT-proBNP between 400 and 2,000 to get an echo within 6 weeks, and we're probably near on 100% of patients doing that now. So our echo team have done a great job. When the echoes have been done, I basically review all the echoes, and I can triage them to the most appropriate clinic, whether it's and we've seen all sorts of different things on those echoes, including severe valvular disease, signs of symptoms of core pulmonary respiratory disease, pulmonary fibrosis, ended up being the diagnosis, and also massive PEs. And we've diagnosed those relatively quickly at the point of their echo, and I can triage them either to come into AMU or refer them on to respiratory with the appropriate ongoing tests. So there was that initial triage has been quite helpful. When it was obvious from the echo of the diagnosis, then we could either invite them to clinic if there's a significant problem we're going to help with, or if there isn't a significant problem with the heart and they don't really need to see a cardiologist and we can manage them remotely, then great. They get invited to the MDT. They might not need to come and see a cardiologist. We've picked up a number of cases of atrial fibrillations that weren't picked up, and they just needed rate control and reassessment, which we're able to facilitate through the MDT. So in terms of cost saving over the last year, in terms of appointments, about £55,000 worth of savings in just outpatient appointments alone. That doesn't take into account any potential inpatient stays. So a relatively good cost saving, even on the initial funding from NHS England, and we still have money left from that initial 40,000. So it's covered well over a year in terms of heart failure MDTs. So with that triage, we now have some urgent heart failure slots. So if I think the echo significant findings, we will see people within 2 weeks. And if it's routine, then we're seeing them within 6 or 8 weeks after the echo. Usually, because we don't have a waiting list, I think we're probably the only hospital in the region that doesn't have a waiting list for their heart failure clinic. We're often seeing all these patients within 2 weeks, 2 to 4 weeks. Okay, next slide then, please, Dan.
Slide 13 now.
Slide 13. And this has continued. The trend now is just, I didn't have time to make nice graphs of the, but essentially the trend's continued, and if not, we're preventing even more cases. So 56 cases that would have reached us in clinic just in a couple of months. Next slide, Dan. So I've left these just in terms of the feedback. So we sent a very basic survey, a lot of tick boxes, mainly to see whether the format was correct, whether the times were correct for the people that might be using it. And it's impossible to find a time that's suitable for all. We currently have 2 MDTs a week. They are at 12:45 till 1:15, so half an hour slots, and people can book on for appointments if they need to, or just turn up. Well, everybody that's used the service, the cardio oncologists, the oncologists, and the primary care users. The last one was an extended one where we had a 93-year-old man that had gross fluid edema, testicle, sacrum, all swollen, and he had a low sodium. I think the sodium was 124, and there was a question about whether it needed to be omitted for IV antibiotics, IV diuretics, and we managed to manage him with loop diuretics and heart failure management. But I think just the last line there is a bit of a barrier. I mean, we're quite used to manage heart failure, but heart failure is actually quite difficult to do well, I think. And people don't want to bring cases to meeting because they don't know what they don't know, or they feel like they do know and they don't. It's an area that confidence is not high in for some reason, and whether that's just education or previous experience. Next slide, Dan.
15.
So, as I said, I had some case examples of people that have come through our pathways, and I don't really want to demonstrate how bad we were, but we weren't great, and now we're a lot better. So, but just some examples. I just want to keep an eye on the dates and time frames of this. So this is a 74-year-old lady that been breathless since May. She was in AF, so found to be an atrial fibrillation. She did an interpreted. So I assume this is what the thought of why she was breathless. She was in atrial fibrillation. In August, sorry, so 3 months later, this was the first NT-proBNP, which was 2000. Unfortunately, a couple of weeks later, she ended up coming to hospital. She went to A&E, and she was breathless, and she was tachycardic. She was given some furosemide, but no rate control. Not quite sure why. And then she was seen, as I said, by the cardiac nurses on the 15th of September. So we're already 6 months past her symptoms, and look, it's terrible. This is regards to symptoms. This is just an excerpt from my colleague's letter. I wasn't involved in this case, so it's an excerpt from my colleague's letter. There's like swollen legs above her knee, and she's been sleeping upright because she can't lay down flat. I mean, this lady's been struggling with these symptoms for I don't know how they've progressed, but I mean, she ended up in A&E. So I should imagine between the 27th of August and the 15th of September, she's been extremely struggling. Next slide, Dan. Sorry.
16.
She did get better with a bit of furosemide, so she must have been terrible. She started losing weight on the diuretic. So the furosemide, and we hopefully know now the diuretic is essentially the foundation of the 4 pillars of heart failure therapy. Some people describe it as that. And you need to try and aim for euvolemia with these patients, and you can do that with the SGLT2 inhibitors and MRAs, but they're not very potent diuretics. So often people need loop diuretics in addition to these medications to offload them. So in clinic, we didn't have the echo, which was a bit fast, so they advised further rate control in clinic pending the echo, and the echo was done on the 27th of September. She was still fast. She had severe LVSD, severe or impaired right ventricular systolic function, and the prognosis once you get impaired RV function as well as LV impairment is much worse. And then that went back to the cardiologist. So this is now 2 months. Work out my maths. So 5 months after her symptoms started, 2 months after she was referred into clinic. But unfortunately, the clinic letter hadn't been typed, so at the time it wasn't until the 26th of September, so she not received the additional rate control, which I'm sure would have helped her. And she was referred to the heart failure specialist nurses. it wasn't easy to get hold of this data. So I'm not quite sure when she was seen or when the one medication she was started. But even when she was seen in cardiology clinic in May the following year, she still had some symptoms, and she hadn't even started an MRA. So we're now a year on after her symptoms have started, and we've still not optimized her heart failure therapy. She did have an echo 3 months later. She was now rate controlled. The LV function had improved, borderline low. And in October, so the following year, her symptoms have resolved. But this poor lady had symptoms from May the preceding year. And I'm pretty certain if we'd have got some rate control quickly and the right heart failure medication, we could have made her better in a much shorter time frame and potentially avoided her coming to A&E. So that's all I'll say. That's where we were. And this is not an unusual story. Unfortunately, it wasn't. So we made these changes to the heart failure pathway, and where we are now, this is sort of characteristic of where we are now. Again, there is some education. We try to spoke at a number of meetings about heart failure needs to be thought of on anybody that presents with breathlessness or leg swelling. And an NT-proBNP is quite a good screening test. I would suggest if people don't have productive prurient sputum or a temperature, then NT-proBNP should be done, or any other reason why their NT-proBNP will be up that's not heart failure. Unfortunately, again, this 72-year-old lady, after the antibiotics didn't work, presented to A&E on the 23rd of December, and she was obviously maybe not a classical history of heart failure, but she was diagnosed with an exacerbation of COPD, given inhalers, steroids, and sent home. On the 30th of December, so a week later, an NT-proBNP was 4,700. Just to put that into context, if you've got signs or symptoms of heart failure, an NT-proBNP of greater than 2,000, you've got a sort of 95% chance of having heart failure. The GP started some furosemide at that point, but no other heart failure, no other prognostic heart failure therapy. And of course, now we have some drugs that have got licensed indications or are helpful in both HFrEF, HFpEF, and heart failure with mildly reduced ejection fraction. She was referred at that point. We got her echo done on the 15th of January. Severely dilated, severely impaired LV function with the ejection fraction of 25%. So at that point, the GP was invited to our heart failure MDT, but there wasn't really much time for them to attend because we managed to get to see her on the 20th of January. Breathless walking. This again excerpts from my clinic letter. I'm not sure if I was involved at the time or after. Breathless walking in the clinic, lie propped up with pillows, short of breath, feels tired a lot and has no energy. So now we knew the diagnosis, we know she's got HFrEF, then we're able to start the ACE inhibitor, an SGLT2 inhibitor in clinic. Those of people that have been involved with our pilot pathway, depending on what I feel is the cause of heart failure, depends which order of medications I start them on. And this looks like I was suspicious that hypertension had a role in her heart failure, but it's not really a session to talk about that. But and we referred to the heart failure specialist nurses at that point. She was established on all the four pillars of heart failure therapy by the heart failure specialist nurses within a month. Next slide, please, Dan.
Slide 19.
Slide 19, yeah. Oh, sorry, mine's not moved. I was waiting for it to go up. So much more slick process, although it wasn't involved in the MDT on this occasion. The next part, so we thought we were doing pretty well at that point. And having a conversation with some of my colleagues, we thought we might be able to improve this further. So we developed, in collaboration with some primary care practices in Doncaster and in Bassetlaw, a pilot pathway. As I said earlier, if you've got heart failure, if you've got an NT-proBNP greater than 2,000 and you've got signs and symptoms of heart failure, you are likely to have heart failure. So why do we need to wait for a specialist review and an echo when we've got some treatments that are safe and effective, particularly in preventing morbidity and mortality and hospital admissions within 30 days? So this there's not many people. This is why I say where we want to go, because again, we've had even though a lot of practice were involved in sort of creating this pathway and said they were keen to try this, we've had very little in the way of people referred directly on this pathway. And I'll show you the pathway later on. So in July, so again, same similar sort of story. In July 24, patient cough, shortness of breath, query chest infection, treated as such, went back on the 22nd of July, no better. NT-proBNP nearly 4,000 in atrial fibrillation, given some furosemide. But also, along with the furosemide, they started a beta blocker and an SGLT2 inhibitor as part of our pilot heart failure pathway. So already 2 of the 4 pillars of heart failure. In fact, they were already on ramipril 2.5 milligrams for hypertension. They did repeat the NT-proBNP, which was part of our pathway, and things have got worse. So, and you'll see the pathway in terms of the escalation process. So we know, despite these good heart failure therapies, we are not doing well, because despite that treatment, their NT-proBNPs got worse. However, we knew what the problem was by then, because we'd had an echo on the 26th of July, which showed he got severe LVSD, and at that point, a referral was made to the heart failure specialist nurses. On the 5th of August, we managed to see him in clinic. He was still struggling with symptoms, so despite that treatment that was started by the GP, still sleeping on 4 pillows, swelling his legs up to his chin. And our job wasn't that difficult in clinic then. So next slide.
That's 20.
So we started a bit of data, so it must have been atrial fibrillation, so I missed that. We started on some spironolactone, so an increase in furosemide because there was obvious signs of fluid overload. So now, already, before even seeing the heart failure specialist nurse in the community, they were already on the 4 pillars of heart failure therapy, and we'd only been a month since their diagnosis. Usually what I tend to do to look for cause of heart failure is I usually start on medical therapy and do an MRI scan, usually at 6 months, to allow the medications to work. But this guy, I remember clearly, had it a bit earlier than I'd hoped. We can already see his LV function has gone from 25% to 39%. So we're on the right tracks. His medications are working. So we reviewed him in the correct time period in January. And this is, again, an excerpt from clinic notes. So he started medical therapy. There's been significant improvement in his symptoms. He's no longer breathless, can manage hills and stairs without any issue. So a relatively quick success with less involvement from a number of people. They just have to optimize the dose of the medications rather than initiating. So that's just nice. As I said, we have very few cases referred on this pathway, but I think it illustrates it nicely, that one. So I'll pause there if anybody's got any questions, and I'll just walk you through the pathway that we created. In fact, this isn't projecting very well. So any questions at all about what we've managed to do so far in terms of heart failure?
I do have one question, if you don't mind. My name's Marie Hutchinson. I'm one of the community heart failure nurses in Sunderland.
Oh, hello.
Hello. I just wanted to ask, why did it take so long for to get through to the community heart failure team on that referral?
Which referral?
This referral you're talking about, you know, when they were already on 4 pillars before they've actually getting through into the service on the last one that you've just spoke about.
It didn't take long at all, did it? From diagnosis, so this is where we want to. So diagnosed on the 12th of on the 22nd of. He was not even diagnosed then. So he's seen a GP who suspected heart failure on the 22nd of July. We found out he got severe heart failure on the 26th of July. And we saw him in clinic in the 5th of August. So it's taken 14 days to get him on all 4 pillars of heart failure therapy. and a diagnosis
So he was
from seeing the GP.
right. So he was seen by the heart failure nurses in the community at that time, was he?
Not even seen the heart failure. Not had
Okay.
time to get to the heart failure nurses because we're that efficient in clinic. So I don't know what your waiting list is for heart failure specialist nurses, but ours is at least 2 weeks from point of referral. And at that point, we didn't even have a date. You can't refer him on the 22nd. The only time you can refer someone is on the 26th of July. And we'd already seen him in clinic by the time the heart failure nurses had picked him up. And then, I mean, speaking from our heart failure specialist nurses, is it easy? We've already started. We're on the 4 pillars of therapy. All we need now is to optimize his loop diuretics and up titrate to his maximum tolerated doses. So we've done, I'd argue we've done quite a bit of the work for the heart failure specialist nurses already within a week to 2 weeks.
Amazing work, simple as. We're not needed anymore if you're working that effectively. That's amazing.
And that's why we want to go. And as I said, we've just been a bit disappointed that absolutely you're never going to be replaced. In fact, as I alluded to earlier, there are far too few heart failure specialist nurses that are rugged, ragged. Our patient list on our heart failure services are huge, and that's why there's a big delay. So and I don't think we're alone. I don't know if there's any other heart failure specialist nurses in the region, but I've heard stories of people waiting 4 to 6 weeks to see a heart failure specialist nurses with severe LVSD. I don't think that's that uncommon.
It isn't from our point of view, I've got to say. I mean, our caseloads are about each. We've got 120 patients each. Yeah. So therefore, yeah, you're quite right.
Yeah. So there's not enough of you. We were trying to unburden that service or prevent the stress, so you can focus on the other things that are important in community. Not just medications. I mean, heart failure specialist nurses do a whole load of things, and a lot of it is counselling, taking people through rehab, talking to them about their disease and letting them understand it. And that's the psychological effect of having a diagnosis of heart failure. It's terrible. So it's not just about medications. We want to try and take some of the routine burden as it get these patients feeling better as quick as possible.
Great. We've got a question from Christian Bailey, who's got his hand up.
Chris Bailey, a cardiologist in Newcastle. I think your talk has highlighted nicely the unintended consequences of access to NT-proBNP, and the lack of recognition that it's not a very specific test in that intermediate range. So we realized many years ago that our rapid access heart failure clinic was just overwhelmed with patients with intermediate NT-proBNP who were breathless because of their COPD and had swollen ankles because of their amlodipine.
We don't see them.
So while we switched a long time ago to a very similar system to this. So those with intermediate NT-proBNPs, the echoes get reviewed by the heart failure team, and advice and guidance goes back to the GP, and they either get brought to clinic if necessary or not. What we don't have is the virtual MDT aspect of this. So that's something that maybe we should consider. But it does mean by providing that sort of streamlined service that we can see the patients who are going to benefit, such as this patient, quickly and within 2 weeks, and get them sorted rapidly. So I think it is important that we make sure that appropriate triage and not following a one-size-fits-all approach is utilized for these patients.
That's why we found the heart failure MDT quite useful, because although we are pretty good at interpreting echoes, there are people with HFpEF that have a fairly normal looking echo. Even, I mean, yeah, a bit of borderline LA dilatation, not much in the way of diastolic dysfunction on the other Doppler parameters, and they can slip through the net. So I felt just triaging on echo alone without actually speaking to the patient or seeing their progress I would be on a bit of unsafe ground. So that invites the MDT. Our letters, the ones that we don't see in clinic, we don't send advice and guidance. If there's an obvious diagnosis or an obvious cause, then we direct the GP. But even now, in some cases where we've got patients that it looks like this is obviously HFpEF, I've got a standard letter that I say if the patient's relatively frail, I mean, you can argue about whether this is all right or not because you need counselling properly about SGLT2 inhibitors in a frail patient. But in people that are relatively young, ambulatory, and don't look like they've got contraindications of these medications, I sent a letter out saying that HFpEF can be managed pretty well with weight loss, management of diabetes, management of hypertension, and SGLT2 inhibitor and MRA and titration of loop diuretics. And it's a standard letter, and then I invite them to the MDT, and if they've not got anything, if they've not got better on that treatment, they bring them back to clinic. Obviously, if they've got other features that we're worried about, amyloidosis and things which is underdiagnosed and are always suspicious on the echo, then we bring them into clinic. But we've not had any problems with the triage, and that MDT is just giving us a bit of a safety net. Well, thank you.
Rao, do you want to come in?
Yes, thanks, Dan, and hi, Garrett. Hope you remember me. I worked with you at the beginning when we developed this pathway. So I'm a GP in Doncaster for others. I just was trying to reflect on, the poor uptake of this MDT invite. I think it's probably, although, it's a great service and great offer, it's not quite always sort of feasible for GPs to kind of attend those two fixed times. Not many GPs actually work all 5 days, and either they are not there or, they might not be able to hand over to somebody else to attend. So that's one thing. And the other thing about the pathway itself is you said not many people are actually referred via the pathway. I'm still wondering whether it's widely known, or it's not just the GPs or the lead GPs knowing, but also the admin staff and knowing which box to tick while they're referring, and all these kind of nuances probably need revisiting. So I'm happy to sort of reconvene and sort of look into things and see what we can do. But yeah.
We've also got people from different regions. I think one of the issues is we've got so many different forms for the same service is the issue here, Al. So I was hoping, this isn't our referral pathway. It was initially planned to be our referral pathway, but it couldn't be digested by the by System 1 out in the community. So we've now got a basic Word document referral, but we try to slimline it as much as possible in terms of information required. We don't need anything. The main thing I'm interested in is about functional capacity. If I've got someone that's got an NT proBNP, I've got a cardiologist on the course, I have to be a bit careful because it could be a bit of debate here. But if I've got someone who's got an NT proBNP of 4,000, but they can walk 5 miles, I'm not that worried. If I've got someone who's got an NT proBNP of 2,000, they're breathless tying their shoelaces, then I need to see them in the next week or so. That said, the only real good biomarker for prognosing heart failure is NT proBNP, so the one that 4,000 is in trouble. But I'll just walk you through. So these are the required. So basically, require some symptoms, and we've even put at the request of colleagues, fatigue likely due to heart failure. And this is often, I think this alludes to my cardiology colleagues' comments earlier. NT proBNP, the interpretation, if you're going to request a test, you need to be able to interpret it to some degree. And we see so many false positives from chest infections, atrial fibrillation, renal failure. So you've got to be able to interpret the test. So I would not do a tide all the time screen that includes an NT proBNP unless you've got another symptom, breathlessness, shortness of breath. Otherwise, we'll end up clogging up or preventing seeing the people that do need to see. We do want to try and exclude atrial fibrillation from at least as a parting cause. But of course, many people with atrial fibrillation do have heart failure, particularly heart failure with preserved ejection fraction. And if you look at the numbers, we went special. We tried to make things as simple. We were following the NICE guidance, and most of the other cardiology guidance follows this, because if you start being so sensitive, you end up missing loads of people that have actually got heart failure. So if you look at the data, the the upper limit of normal for someone in atrial fibrillation without heart failure is between 800 and 1200. So when you've got anything above 2000, even with atrial fibrillation, you're likely to have a degree of heart failure, which I meant to comment earlier. So, our pilot pathway, we get in slightly in addition to the heart failure MDT and our triage processes. We did look at all the flight of ideas now. We did look at all the options in terms of our heart failure clinic. So many patches in our region do one-stop heart failure clinics in terms of echo and seen by cardiologists on the same day, or echo and seen by heart failure specialist nurses on the same day. But again, they've got 3-month waiting list for a new patient appointment for heart failure, because we're seeing all the people with atrial fibrillation, coughs, colds, COPD, and all the other reasons because of that, the non-specificity of the NT-proBNP. So I absolutely agree with. Sorry, I didn't catch which location you were from. To Newcastle, I think, and it fits with all the GIRF. Saying that we should have the diagnostic test at the time of seeing the clinician, and we've not. Although a lot of our patients with heart failure end up coming back twice to hospital, they come one day for an echo, another day for an appointment. Our patients seem to prefer it rather than waiting 4 hours. We spoke to them about it, rather than waiting 4 to 5 hours for an echo, coming in at 8 o'clock in the morning, leaving the hospital at 1 p.m., which is what happens when you're in a one-stop heart failure service. So the feedback that we've got from the patients is pretty good.
I'm going to give you 3 minutes, if that's all right, Gareth.
Yeah, sorry. Well, so the pathway blood tests that are useful in heart failure, all the NT-proBNP, we want to know the functional capacity, how bad are their symptoms, and then if you've got an NT-proBNP greater than 2000, then we ask people to start them on a beta blocker, loop diuretic, and SGLT2 inhibitor. If you volume deplete people with PE or pericardial effusion, you may end up into running difficulty. So prior to initiation, we do want a clinical examination and just double check the blood pressure and everything's okay. And beta blockers aim for euvolemia or around euvolemia. And there's a little, if you go to the next slide, Dan, which is the final slide, I'll stop rabbiting. I can talk a lot about heart failure. So the last slide is 22 is a pathway in terms of, and what we wanted to do is, to be honest, this is when we had a very long wait for our heart failure referral. So what we want to do is start some treatment and see whether it's working or not. So the plan was to repeat the NT-proBNP, a bit like the last case that I showed, that obviously we weren't winning because the NT-proBNP was going up despite treatment, in which case we can expedite the cardiology review, which we did on this case, or discuss at the heart failure MDT. So we asked the GPs to feedback with that initial NT-proBNP. And in answer to Raoul's question, the feedback that we have from the GPs, I mean, we tried lots of different, we tried before clinics, 8 o'clock in the morning, we tried different days. The feedback was that everybody is just too busy and there's no financial reimbursement, which is a bit sad. There we go. It's the way the world works. That's our pathway. Happy for any other questions, or I'll stop talking. It's a good job Sarah phoning sick, otherwise I'd have wrapped it on for.
Thanks, everybody. So
thank you.
Thanks, Gareth. Yeah. So I thought it might be just worth just sort of summarising that a bit. So Gareth has sort of presented to us a couple of projects, really. They're sort of two merged into one, aren't they, Gareth? This is the virtual heart failure MDT.
It sort of evolved once we got started.
Yeah,
so,
yeah. Which was sort of as a weekly or twice weekly drop in, isn't it? And I think the case studies sort of demonstrate the benefits of this, with the rapid optimization of patients in collaboration with primary care. So that we're sort of getting them optimized quickly. I think the thing that I'd not thought about until today is the palliative care aspect as well. So when a patient really is too frail to sort of go through the whole pathway, or considered to be, fully optimized about how we might best manage them symptomatically in the community. So that's useful. And I think reiterating slide 12, I think is is the sort of one of the keys to me, really, that you sort of had this £55,000 outpatient saving, and actually the costs have been way less than that to run the MDT, haven't they?
They have, so it's cheaper and we're getting better care, so it's
Yeah,
a win-win.
yeah. So it is a win-win, absolutely. So we've sort of demonstrated faster time to diagnosis, reducing their exposure to deterioration admission, the further saving through all those saved appointments, you're sort of improving that relationship between primary and secondary care. Or admittedly, we could do more with that, and that would probably where our focus would be if we managed to continue the service. And then, you know, we have really enhanced the management of these heart failure patients, getting them on their optimum treatment earlier. So really, the point of this is that we would really like to see this sort of commissioners to adopt this as standard practice. So I suppose my question to everybody here is how do we make that happen? You know, who do we speak to? I'm more than sort of happy to open the floor up to discussion if anybody wants to. If people need to drop off, then by all means do so, and we'll bring it to a close shortly. Any thoughts on any of that? We stunned you all into silence. Oh, Raoul, go on.
The question is it like commissioning from the secondary care point of view, or by the ICB as a place and kind of region point of view?
Yeah.
I think probably approaching the Medicines Optimization Committee for South Yorkshire, it's called as IMOC. I think Eben is involved, and she's got her hand up, so probably she can take it up from there.
Hi, Eben.
Hi, everyone. Good afternoon. Just a quick question for you, Gareth. With regards to with regards to prescribing SGLT2 inhibitors, what are your? I'm just trying to frame this question properly. Do you feel that you, or rather, were you able to collect information on how many patients you prevented from going into hospital? Was that the case for every single one of those patients that came to the MDT, for example? You know, were you able to collect that information? And then, you know, there would have been patients who maybe weren't brought to the MDT, but for whom they would have completed that sort of referral form, or, you know, to your clinic based on the NT-proBNP results. Do you have any data as to how many of?
Yeah, we don't have enough patients through on the new pilot pathway to be able to come to any firm conclusions. But I mean, it's data-based anyway. So all the big trials using SGLT2 inhibitors in heart failure, particularly in HFrEF, were very positive in terms of reduction of heart failure admissions. In the HFpEF studies, again, they were positive in reduction of heart failure admissions, but not total admissions. So I think we know, and there's a number of studies suggest that the morbidity and mortality of patients that are started on SGLT2 inhibitors and beta blockers early reduces their 30-day morbidity and mortality. So we're just aligning ourselves with the huge RCT evidence base. Whether we need to, or whether we should prove the benefit in terms of hospital admissions locally, we need more patients. And unfortunately, you've ended up, we tried to collect more specific data, and we are still trying to collect data, but these things take time. I haven't had a need to do that yet. We're working through our heart failure clinics before and after the changes, looking at the difference we've made, but it's quite difficult to do, and I can't do a lot of it in terms of I've tried to get access to this. We're trying to look at auditing our heart failure service and try and get some of that data, but I can't seem to access the data. Even though I've got access to System 1, I can't access a lot of this data about when they first presented to their GP, when they first had their NT-proBNP, and I don't know what to do about that.
We could probably have a conversation outside of this to see if we can sort of unpick some of that. But I think, especially if, you know, the proposal is to look at how we can take this up for wider commissioning, you know, those are sort of the things that could sort of, you know, that could definitely help with facilitating that, you know, the quantitative evidence sort of supporting that. And you know, another question is whether or not do we need to be looking at the thresholds that we're currently using for NT-proBNP, for example, in terms of the sensitivity and specificity, or whether or not we need to, you know, we should keep it as it is. But it's you know, I think it's really interesting sort of that you know, over 2,000 mark as sort of being very a little bit more specific.
It's more specific, yes.
Yeah, and actually whether, you know, that I think is something that's novel beyond what's recommended in national guidance, because, you know, we don't have that in national guidance. And it's
no,
just...
there is clear national guidance for the NT-proBNP, and I don't think we should change the levels for various different reasons. I don't think we need to get into here, but you can normalize an NT-proBNP pretty quickly with a bit of diuretic. So having a normal NT-proBNP doesn't mean you don't have heart failure, and you can get false negatives as well in people that are obese and some other causes of false negatives with medical therapy. So yeah, I think it goes back to, if you're going to request a test, you need to be able to interpret the findings in the clinical context. And part of that is education. That's why the MDT was there, so people see how we manage heart failure in secondary care.
And was there a strategy for deprescribing? So where patients, I mean, you know, where patients had a raised NT-proBNP and were referred to the clinic and eventually had an echo and were found not to be in heart failure, was there a strategy for deprescribing the SGLT2s?
Yeah.
And the
So
other therapies?
if we see them in clinic and they don't have heart failure, we just stop the medication.
Okay.
If you think about it, in terms of SGLT2 inhibitors, most of our patients, particularly ones with HFpEF, are multi-morbid, and the ones that have got heart failure, some of them have got chronic kidney disease or diabetes, so they've already got another indication for an SGLT2 inhibitor. So we just assess that, and if they've not got any other indication for an SGLT2 inhibitor, they get stopped.
Okay, I'm happy to meet outside of this meeting, obviously, to look at how to put, you know, take these further. But thank you very much.
That'd be useful. Thank you, Eben.
I'm going to leave. I've got CT list.
Yeah, I think we're going to bring it to a close. Thanks everybody for your time.
Thank you.
And for your comments and interaction. I think hopefully it was a very useful session for everybody. Thanks very much.
All right.